Assalamu alaikum. My name is Dr. Sayyad Saibar and my moderator is Dr. Kaleem. So today we are presenting CT scan and MRI and their role in our practice in urology. So starting with the introduction of CT scan. In 1979, Nobel Prize in the Medicine and Physiology was awarded to Alan M. Pomar and Sir Godfrey Hounsfield for the development of CT scan. CT scan imaging is the attenuation of X-ray photons as they pass through the patient's body. The single spiral CT scan introduced in 1988 had a single row of detector and required multiple passes to visualize a small area of interrogation. But now the standard scanner is used today have between 64 to 320 rows of detector. So entire patient's body to be imaged during a single breath hold with few or no motion artifact, more precise and diagnostic accuracy, increased concentration of contrast material, shorter the scanning time and less radiation exposure, and significant increase in the anatomic coverage. So what are the Hounsfield units? These are actually the grayscale of each pixel on a CT depends upon the amount of radiation absorbed at that point, which is termed as a attenuation value. The attenuation value are expressed in Hounsfield units. So these are the few Hounsfield units of different material. Like air has Hounsfield units of -1000, fat between -100 to -20, water 0 to 20, soft tissue or dense fluid between 10 to 50 Hounsfield units, calculi or calcification more than 100 Hounsfield units, and bone between 1000 to 2000 Hounsfield units. So on the basis of Hounsfield units, we can see or we can differentiate the different types of tissues, or we can differentiate between the stone, calculi, bone, calcification, soft tissue. So increase in the Hounsfield units with IV contrast is equal to Hounsfield unit of lesion on contrast image minus Hounsfield unit of lesion on non-contrast images. So the Hounsfield units of a lesion are less than 10 on non-enhancing or non-contrast CT, between 10 to 20 on intermediate, and more than 20 on IV contrast. So first plain or non-enhanced CT, which we are commonly used for the stones in our practice in urology, in which we can see the renal, ureteric, bladder or urethral stones. For urolithiasis, the plain CT has a sensitivity between 95 to 98% and specificity of ranging between 94 to 99%. So in plain CT, we can differentiate between different masses that can be present to uncover the kidney stones. Later these stones can be obscured by the excretion of contrast in the pelvic calyceal system. So this is the first CT which we put in our presentation. Can anybody from the audience can describe the findings of this CT scan? Is the CT scan is contrast or non-contrast or plain CT scan?
Dr. Asad, your comment on this scan. Which section is this, and it is contrast enhanced or non-contrast? So as per Dr. Asad, Dr. Sayad, it is axial image and non-contrast image.
Okay, very true. So moving towards the next CT.
Dr. Bilal, is it contrast enhanced or non-contrast? And which section? Oh, you are right. Sayad, proceed.
Okay, sir. So anybody describe the findings in this CT scan?
Dr. Uzma. Right kidney is normal. Comment on left kidney. Grossly hydronephrotic and multiple cysts. Which is most likely? So there is no cyst in this kidney. Grossly hydronephrotic kidney with hydroureter. We can appreciate tortuous ureter and parenchymal thinning or paper thin cortex. So Sayat, proceed.
Okay, sir. So we have few more images.
Anyone comment on this CT scan? So you are right, there is a bilateral renal stone with paper thin cortex on right side. Sayat, proceed with next CT scan.
So this
Anybody from audience? Bilateral pugio and any other finding in right kidney? So lower pole, non-obstructing secondary stone. So bilateral pugio, as you can see, pelvic dilatation on right side. There is significant calyceal dilatation with on right side. Secondary stone, which is non-obstructing. Any senior resident comment on this CT scan, this image? Dr. Adil. So you are right, is a polycystic kidney disease, bilateral multiple, semal, and on right side, large cyst also appreciated. So it is adult polycystic kidney disease. Dr. Abdul Karim.
Contrast the hydronephrotic with hydroureter with distal ureteric stone.
Karim. सयाद एक स्लाइड पीछे.
सर ये सेम ही है, इसकी वीडियो है, कोई सेम ही है.
So do you think whole kidney is distorted or only upper moiety or upper pole of ureter, upper pole of kidney is distorted? So you are right, this is upper moiety, hydronephrosis, tortuous hydroureter and distal obstruction. Mid and lower pole are spared or intact. Sayat, proceed.
So in contrast enhanced CT scan, we use different contrast media. Iodine widely used as a contrast for vascular imaging, which enhance the blood vessels. In iodine contrast media, which are further divided into two components, ionic iodine contrast media, in which positively charged iodine molecule dissociates into iodine and an anion, which commonly uh, present in our patient with allergic reaction. And the other one is non-ionic iodine contrast media, in which neutral molecule and no risk of adverse reactions. So in this slide, we can see the iodinated contrast media. which includes ionic monomers, non-ionic monomers, ionic dimers, and non-ionic dimers. Different contrasts are given as a gastrography and used in most commonly in GI. So the contrast enhanced CT scan helps in urological malignancies, urological abnormalities, preoperative planning, and in workup of hematuria. In contrast enhanced CT scan, we commonly practice in our patients with tumor or masses, in which the sensitivity is around 80 to 88% and specificity of 95%. So in the contrast CT scan, there are multiple phases in which we can see the different components or the different parts of any organ, like arterial phase, portovenous phase, delayed phase, or excreting phase. So the first phase is the arterial phase, which uh, in this phase, the films taken between 30 to 70 seconds after contrast injection. The corticomedullary phase is captured with another pass through the CT, helping to define the vasculature and the perfusion. So anybody in the audience can comment on this CT scan.
Is this contrast enhanced or plain CT?
Sir, contrast.
To contrast enhanced. Any finding? Positive finding? So this is also normal arterial CT contrast. Comment on left kidney. Sorry, right kidney. So this and only on this image one can suspect renal injury. Any other finding? What it can be? Hmm? You're right, renal mass. So we need more cuts or more sections to comment further. होना चाहिए था, लेकिन अगर पेल्विक कैलेसिस सिस्टम इन्वॉल्व नहीं है तो नहीं होता, जरूरी नहीं है. Comment on this CT scan, left kidney. So most of the mass is exophytic, small part is endophytic. This is a lower pole mass on the left side. Right kidney. So after looking at this image, only a single image, is this simple cyst or complex cyst? So it looks like a simple cyst. Sayat, proceed.
So the excretory phase, in which images are taken between 3 to 5 minutes after injection of contrast, the excretory phase allows complete filling of the collecting system and usually allows visualization of the ureter.
Sayat, why we need a excretory phase? Anyone? Indication of taking excretory images. See the obstruction. Any other thing?
To see the washout of contrast.
Wash out of contrast, obstruction, or any upper tract malignancy. Sayat, next. This is normal excretory phase.
This is also normal excretory phase image. So in the delayed phase, in which films are taken between 10 to 15 minutes after IV contrast, which we commonly use in adrenal lesions or benign adenomas. So this is the video of a normal patient with the so anybody can describe the findings in this CT image.
Left. What is the name of this sign? S-shape. So both names are used in literature, S-shape sign or fish hook sign. You are right, this is basically retrocable ureter.
So
Say our
this
next.
is also the picture of the same patient with the right retrocable ureter. So this is the bone window of same patient's CT, in which we can see the obstructed kidney with the ureter passing behind the IVC. So the other ones can anybody describe the point?
You have a look on right kidney. What is different right and left? Although this is not true representative image, but it is the right PUGO.
So these are the few reconstructive images which we commonly use in our patients for transplantation. So anybody comment on this pic?
Or left side में dual sub. What is this pink thing? Anybody? Exophatic left-sided lower pole renal mass, right? And this one, this is the right renal mass.
So this slide also tells about the different phases and the time period. So there is a partial difference in that time period in different books. So in this, the arterial phase in which image taken between the 20 to 30 seconds, in which we can see the kidney stone, ureteric stone, arterial calcification, abdominal bleeding, aortic aneurysm, aortic stenosis, occlusion, hypervascular liver metastasis, and pancreas tumors. Or in the portovenous phase, in which we may take in between the 60 to 80 seconds, in which we do the screening, hypovascular liver metastasis, abscess formation, venous thrombosis, or in the nephrogenic phase, in which we may take in between 80 to 100 seconds, in which we can see the or differentiate different kidney tumors or in kidney trauma, or in the delayed phase in which image taken between 6 to 10 minutes, in which we can see the ureteral obstructions, leaks, and characterize the liver tumors. So this slide on the nephrometry score, which is an important for the pre-planning of the surgery and to define any mass. In this, there are different components of the nephrometry score. On the number first is the radius, uh, which has 3 points. If the radius of any tumor or mass are less than 4 centimeter, then 1 point. If more than 4 and less than 7 centimeter, then 2 points. If more than 7 centimeter, then 3 points. And on the basis of the exophatic or endophatic properties of the mass, if the mass is more than 50% exophatic, then 1 point. If less than 50% exophatic, then 50%, then 2 points. If entirely endophatic, then 3 points. And on the basis of nearness to the tumor to the collecting system of the or the sinus. If the mass is more than 7 mm away from the collecting system, then 1 point. If between 4 to 7 mm, then 2 points. If less than 4 mm, then 3 points. And the next point is on the basis of the anterior and the posterior location of the mass. No points given, but mass should be assigned or descriptive on the A, P, or X prefix. The last one is on the location relative to the polar lines. Is the mass is above, between, or crossing the polar line? Uh, in the first one, entirely above the upper polar or below the lower polar line, in which we can assign with the 1 point, or the lesion crosses the polar lesion, then 2 points if more than 50% of mass across the polar line, or mass across the axial renal midline, or mass is entirely between the polar lines. So the nephrometry score is very helpful in characterizing the renal masses into low, intermediate, or high complexity, and it also helps in decision making for the surgery and for the patient counseling and surgical planning. So now we are moving towards the MRI. MRI makes us the use of magnetic properties of the hydrogen nucleus present in water molecule. Therefore, in all body tissues, the images are described as T1 or T2 weighted images. So these T1 or T2 weighted images are on the basis of the signal intensity. The signal intensity is determined by proton density, T1 relaxation time, T2 relaxation time, and the flow. So loss of signal from a rapidly flowing arterial blood is due to this. So this image is to describe how the MRI machine works. In magnetic field proton, in which different MRI machines on the basis of Tesla between 1.5 to 3 Tesla, proton align along the direction of the field, and an application of pulsed alternating radio waves gives proton energy, which releases hydrogen proton, thereby changing their alignment. When the radio waves are switched off, proton relax or realign into their resting spin state and emit photon energy, which is detected by coils and generate an image, which we can see on our screen. So the first is the T1 weighted MRI images. These are generated by the time to return the equilibrium in the z-axis or the longitudinal relaxation, in which the body fluids has a low signal intensity and appears as a dark or black, and in T1 weighted images fade appears white, and in this image we can see the better delineation of the anatomy. So these are the few images of MRI without contrast. So anybody describe this one?
Senior resident from audience. Mhm. No significant findings.
So the tonal image of the same patient. So now we are moving towards the T2 weighted MRI images, which are generated by the time required to return to equilibrium in XY axis or transfer relaxation in other terms, have a high signal intensity and the fluid appears in this brighter.
This is T2 weighted image.
So the uses are of MRI is that staging of cancer, MRI guided biopsy, investigation of to diagnose the different causes of bloods, ureteric stone in pregnant in during pregnancy when ionizing radiations are avoided, or penile smooth muscle viability in a patient with priapism. Advantages of MRI is the excellent signal contrast resolution of soft tissue without the need of IV contrast. Good for the patients have iodine contrast allergy. No risk associated with secondary malignancies from radiations. Modality of choice in patients who are pregnant and suffer from renal insufficiency. As in patients with renal insufficiency or end-stage renal disease, the contrasts are contraindicated. So these are the few disadvantages in claustrophobia, expensive and longer procedure time required for this imaging. So these are the few contraindications of MRI, which includes pacemaker, aneurysm, clips or coiling, metallic foreign body in eyes or cochlear implants. So gadolinium contrast we commonly use in MRI can be used to speed up the relaxation time of protons, therefore increasing the contrast between normal and pathologic tissues. So the use of MRI in kidney, contrast having a higher signal intensity being brighter than the medulla, which gives off a lower signal and is darker. In cysts, simple cysts have a simple characteristics on ultrasound, CT, and MRI, and in complex we can differentiate or characterize on the basis of the MRI. In hemorrhagic cysts, results high signal on T1 weighted images because of the paramagnetic effects of the products from the breakdown of blood or hemocytes. In angiomyolipoma, only renal mass, this is the only renal mass to demonstrate a decrease in the signal intensity from the corticomedullary phase to nephrogenic phase. In oncocytoma is described with a central scar which is observed as a high signal intensity on T2 weighted images, which is present between the 54 to 80% of cases. In renal cell carcinoma, clear renal cell carcinoma, the most common type of renal cell carcinoma characterized by heterogeneous signal, high signal on T2 weighted sequence because of the presence of hemorrhage and necrosis. Clear cell demonstrates more than 200% signal intensity. Increase in all three contrast phases was significantly higher than chromophobe RCC and papillary RCC. In papillary RCC, when compared with the clear cell RCC, exhibits a homogeneous lower signal intensity on T2 hemocydin deposition in histocytes within the tumor. So, MRI in prostate. Goldberg Swedish screening study demonstrating an approximately 50% decrease in the biopsy if prostate MRI was used in a screening protocol with a PSA threshold of 2.8 nanogram per ml. Prostate MRI usually use the multiparametric MRI consist with the anatomic and functional imaging technique. Anatomic imaging should include T1 and T2 weighted images. Functional imaging includes diffusion weighted 1 and ADC maps, diffusion contrast, A sequence, and possibly spectroscopy. T1 weighted image.
This is an important thing for those who are preparing or appearing for the exam, prostate MRI. Sehat proceed.
T1 weighted images in which normal prostate appears homogeneous, intermediate, or to low signal intensity. So this is the T1 weighted image of prostate.
Next, Sehat.
So in T2 weighted images, zonal anatomy of the gland with high resolution, normal peripheral zone with more high signal intensity, central and transitional zones signal intensities are lower than those in the peripheral zone. Anterior fibromuscular stroma has a high signal intensity. Neurovascular bundles are also outlined. So these in this we can show the we can see the peripheral zone and the fibromuscular bundle and the transitional zone. So this is the T2 weighted image of the patient with prostate CA. T2 weighted image sequences should include a triplanar, axial, coronal, and sagittal image. The normal peripheral zone appears as an area of high signal intensity. The central gland with benign prostatic hyperplasia appears as areas of well-demarcated nodules with a heterogeneous signal intensity. Areas of low signal intensity on T2 weighted sequence can represent the CA prostate, prostatitis, atrophy, scar, post-prostate biopsy, hemorrhage, and benign prostatic hyperplasia nodules. In multiparametric MRI, multiple sequence in which we can see the conventional MRI, which delineate the prostate structure in T1 and T2 weighted images. The uses of T2 weighted image is the diffusion weighted image, is dynamic contrast enhanced image is pre, peri, and post contrast to identify the significant prostate cancer. So the second component of the multiparametric MRI is dynamic contrast enhanced, in which we evaluate the blood flow through the tissue and measure tumor vascularity as increases vascularity and blood flow in cancer. Diffusion weighted images is the third component of multiparametric MRI, in which water diffusion through the tissues compared to benign tissues. Cancer often has a higher cellular density than that restricts diffusion of water through cancer. So the last component is MRI spectroscopy, which evaluates chemical metabolite in tissue. Compared to benign prostate, prostatic cancer often has low citrate, elevated proline, and elevated creatinine. So these are the PIRATES scores, a standardized scoring system to avoid the subjective variation in reporting of multiparametric MRI. PIRATES versus assessment categories. In the first one is very low or clinically significant disease is highly unlikely to be present. The second one is low, in which clinical disease is unlikely to be present, and in the intermediate, clinically significant disease is equivocal. In high, clinical significant disease is likely to be present, and in the last is the 5, in which very high clinical significant disease is highly to be present. These are on the basis of multiparametric MRI. So this is the varied score. Similarly, as we can use in the prostate, we also use in the bladder. The number one is the muscle invasion is highly unlikely. When the varied score is 2, then the muscle invasion is unlikely to be present. In 3, presence of muscle invasion is equivocal. In 4, muscle invasion is likely. And in 5, invasion of muscle and beyond bladder is very likely. So these are the vesical imaging radiations. Thank you.